Hi everybody, welcome to this video. I'm Shilpa. If you haven't listened to any of my videos or heard of my tutoring sessions before, so usually when I do YouTube videos or tutoring or anything like that, I like it to be a little bit more engaging and a little bit more fun. But I think that for step 2, there's just so much material to cover that unfortunately the best way that I can think to do it is just give out just a ton of information that I'm studying for and that I think would be helpful for you if you're studying for step 2 as well. And so I know that there's just a ton of material and it can get overwhelming at times, so I hope that this does help. If you do have any questions at all, feel free to leave them in the comments below and I'm happy to answer anything. I'm usually pretty responsive when it comes to answering questions, so feel free to leave any comments or questions below. So let's get started then. This is psychiatry. I have other psychiatry videos as well. This is going to be a little bit of a longer one, so please do stay until the end. I know that it's a long time, but if you double time the speed, then it shouldn't take as long. Okay, so let's get started. What drug intoxication presents as emotional ability, slurred speech, ataxia, and blackouts? That would be alcohol. And then so there are different symptoms and signs in terms of alcohol. So there are and in terms of alcohol withdrawal, so when you think about alcohol withdrawal, it's important to know time frames of when to expect certain symptoms to happen and when to expect certain symptoms to be resolved. So 3 to 36 hours, there's going to be minor symptoms similar to other depressants. From 6 to 48 hours, you're going to have withdrawal seizures. From 12 to 48 hours, you're going to have alcoholic hallucinosis, and that's usually visual. Remember that that's a high yield point that's usually visual rather than auditory hallucinations. And then from 48 to 96 hours, that's when people get DTs in 5% of cases. So 3 to 36 hours, minor symptoms similar to other depressants. 6 to 48 hours, withdrawal seizures. Alcoholic hallucinosis occurs between 12 to 48 hours, and then DTs occur between 48 to 96 hours. So next question is, what drug intoxication presents as respiratory and CNS depression, pinpoint pupils, and decreased gag reflex? That would be opioids. So again, if there's respiratory and CNS depression, meiosis, and decreased gag reflex, you want to think about opioids such as heroin. And then which drug withdrawal is associated with yawning? So as opposed to the last time we talked about intoxication, this one is associated with yawning. That would be opioid withdrawal. Which drug withdrawal is associated with piloerection? That would be opioid withdrawal. What class of drugs is the most common cause of drug overdose death? That would be opioids such as heroin. And then which is the treatment for opioid overdose? That would be naloxone. And then what drug intoxication typically presents as pupillary dilation, grandiosity, vasospasm, and paranoia that lasts for less than 1 hour? That would be cocaine. So if there's pupillary dilation, grandiosity, vasospasm, and paranoia that lasts for less than 1 hour, that would be cocaine. And then you want to be aware that benzodiazepines and alpha blockers are the treatment options. Beta blockers are contraindicated. So fibrinolytics are not indicated because they can cause hemorrhage. You can give aspirin, and CCBs and nitroglycerin can be given for pain. So next question is, what is the treatment for PCP intoxication? That would be benzodiazepines, so rapid-acting antipsychotics. And then next question is, what drug intoxication presents as euphoria, heightened emotional, tactile sensation, and teeth clenching? That would be ecstasy or MDMA. And it also may present with euphoria, distorted sensory and time perception, hyperactivity, as well as hypertension, hyperthermia, hyponatremia, and serotonin syndrome. There's like life-threatening effects of ecstasy, and those are going to include hyperthermia and hyponatremia. And it may also cause life-threatening hypertension and tachycardia. You want to treat with normal saline and cooling if they have hyperthermia. And then, so the way that the hyponatremia develops is that they have a dry mouth, they develop thirst, they increase the water intake without electrolyte depletion, and then that leads to hyponatremia, which can then lead to seizures and life-threatening cerebral and pulmonary edema. So it can be very devastating. It can be a very devastating intoxication if not caught early. And the next one is more points about ecstasy include life-threatening effects include serotonin syndrome, because there's increased release and inhibited reuptake of adrenaline, norepinephrine, serotonin, and dopamine. So that leads to sympathetic stimulation and hallucinogenic effects. And of course, the risk for serotonin syndrome is going to be increased when they're on other serotonergic agents, such as like antidepressants. So St. John's wort is an inducer of CYP450. It's to be avoided in SSRIs or SNRIs because it can exacerbate serotonin syndrome. If you see a spiral fracture, that occurs in response to a twisting force on the bone that's highly specific for child abuse. So spiral fractures are associated with child abuse. So we'll go back to cocaine one more time. Cocaine inhibits the reuptake of norepinephrine, causing alpha and beta adrenergic stimulation. Remember that beta blockers are contraindicated though. So the treatment is going to be benzodiazepines to reduce anxiety and agitation. And beta blockers are contraindicated. I cannot state enough how important it is to know that beta blockers are contraindicated. And then they can also be treated with, as I said before, aspirin, nitrates, calcium channel blockers. And then again, beta blockers are contraindicated. So as a side effect or side note, cocaine is a sympathomimetic, so it leads to vasoconstriction. Next question is, what is the likely diagnosis in an elderly male that presents after months of agitated behavior / moving around in his sleep in the early morning hours? The patient is easily arousable and confused for a few moments after awakening. He describes a recurrent dream where he feels trapped. That would be REM sleep behavior disorder. So this is REM sleep behavior disorder. In older patients, REM sleep behavior disorder may be a sign of neurodegeneration. Maintenance therapy for bipolar is either lithium or valproate plus a second generation atypical antipsychotics such as quetiapine. What are the laboratory tests that are most important to monitor in patients taking second generation antipsychotics, such as olanzapine? That would be fasting glucose and lipid levels. You're looking for metabolic syndrome. So naltrexone is contraindicated in patients taking opioids and those with acute hepatitis or liver failure. Acamprosate may be used and is to decrease cravings and is initiated after abstinence is achieved. So this is for alcohol use disorder. So you can use naltrexone or acamprosate for alcohol use disorder. Second line is disulfiram. Disulfiram is second line because that is an agent that is going to cause there to be like they get like negative side effects from like when they drink alcohol. It's like the same as like using like metronidazole and taking alcohol. You get that like those negative side effects. So that's the reason or the rationale behind prescribing disulfiram, but it's not first line. Naltrexone and acamprosate are first line agents. So the next one is DSM-5 criteria for generalized anxiety disorder include A, excessive anxiety and worry for at least 6 months of time, B, difficult to control. C, at least 3 of the following symptoms: restlessness, fatigue, difficulty concentrating, irritability, muscle tension, and sleep disturbance. Clinically significant distress or impairment. E and F, not better explained by another medical condition, mental disorder, or substance use. So remember, at least 3 of the following symptoms should be present: restlessness, fatigue, difficulty concentrating, irritability, muscle tension, and sleep disturbances. You're also going to want to know what the first-line treatment for generalized anxiety disorder is. So CBT is first line, and then SSRIs and SNRIs, and then buspirone. So second-line agents include benzodiazepine and buspirone, and then there's some confusion because some say that buspirone is a first line, and some say that it's a second line agent. But generally, if you see generalized anxiety disorder, then make sure that you answer either CBT or SSRI, depending on what the answer choices are. Blockage of which dopamine pathway is responsible for symptoms of gynecomastia, sexual dysfunction, and infertility. That would be tubuloinfundibular pathway. So again, to repeat, blockage of which dopamine pathway is responsible for gynecomastia, sexual dysfunction, and infertility in patients taking antipsychotics. That would be the tubuloinfundibular pathway. And that's due to hyperprolactinemia, so other symptoms are going to include amenorrhea, galactorrhea, and infertility. Okay. And blockage of which dopamine pathway is responsible for extrapyramidal symptoms in patients taking antipsychotics. That would be the nigrostriatal pathway. So that's like acute dystonia, akathisia, and Parkinsonism. So this is the mnemonic: MA, mesolimbic antipsychotics; NE, nigrostriatal, extrapyramidal, and TH, tubuloinfundibular, and hyperprolactinemia. Blockage of which dopamine pathway is responsible for the therapeutic effects of antipsychotics. That would be the mesolimbic pathway. Major neurocognitive disorder, such as dementia, may be distinguished from normal aging by the dependence of others for activities of daily living, so ADLs. In normal aging, people can perform ADLs independently. What drug withdrawal presents with nausea, muscle joint aches, diarrhea, abdominal cramping, and pupillary dilation? That would be heroin or opioid withdrawal. Other common findings include yawning, lacrimation, and piloerection. What is the likely diagnosis in a young woman that presents with periods of binge eating followed by guilt, depression, and excessive fasting and exercise? BMI is 19.5. That would be bulimia nervosa. If it's less than 18.5 for BMI, that would be anorexia nervosa. What is the likely diagnosis in an elderly patient with bipolar disorder that develops confusion, tremors, ataxia, and vomiting, and seizures 2 weeks after beginning atenolol and hydrochlorothiazide? That would be lithium toxicity. Do not give to patients with renal disease. So drug interactions for lithium include hydrochlorothiazide, NSAIDs, ACE inhibitors, tetracyclines, and metronidazole. What is the likely underlying pathophysiologic mechanism of tardive dyskinesia? That would be D2 receptor upregulation and supersensitivity. Compared to PCP, the effects of methamphetamine generally last longer. What pharmacotherapeutic medications can be used to treat NMS? That would be dantrolene or bromocriptine. However, discontinuation of the causative agent is the most critical intervention, as well as intensive supportive care. What symptom is associated with neuroleptic malignant syndrome? That would be lead pipe rigidity versus hyperreflexia and myoclonus, which is seen in serotonin syndrome. So next one is diagnosis of a manic episode, which requires an elevated or irritable mood. plus 3 dig fast criteria. So remember, dig fast, D is for distractibility. D is for distractibility. I is for impulsivity. G is for grandiosity, so inflated self-esteem. F is for flight of ideas, racing thoughts. A is for agitation / increased activity. Sleeplessness is what S stands for. Talkativeness or pressured speech is what T stands for. The DSM-5 criteria for bipolar 1 disorder include criteria that have not been met, or criteria have been met for at least one manic episode. Symptoms are the cause of social or occupational distress or impairment, not better explained by another medical condition, mental disorder, or substance. DSM criteria for bipolar 2 include criteria for meeting at least one episode of major depressive disorder, one hypomanic episode, and no history of mixed or manic episodes. Not better explained by another medical condition, mental disorder, or substance. The symptoms cause social and occupational distress or impairment. And then lastly, I just want to go through SIGI caps for major depressive disorder. So that would be sleep changes, interest decreases, guilt or feelings of worthlessness, energy loss or fatigue, concentration deficit, appetite, weight changes, psychomotor agitation or retardation, and then suicidality. And then let's go through tricyclic antidepressants as the last point for this video. So clinical presentation is going to be different based on the system that you're looking at. So for central nervous system, I think about mental status changes like drowsiness, delirium, and coma. Then there's also seizures and respiratory depression. And then for cardiovascular, there would be sinus tachycardia, hypotension, prolonged PR, QRS, and QT intervals, as well as arrhythmias, such as ventricular tachycardia or ventricular fibrillation. For anticholinergic, that means that there's going to be dry mouth, blurred vision, dilated pupils, urinary retention, flushing, or hyperthermia. And then management is supportive care and therapy. You want to give supplemental oxygen, intubate as needed, IV fluids. You want to give activated charcoal for patients within 2 hours of ingestion. And then if they have any QRS widening or ventricular arrhythmias, you want to give sodium bicarbonate. That's all for this video. We'll continue on in the next video. Thank you for watching. Bye.